My name is Susan Jack, and I am the Global Nurse Family Partnership Research and Evaluation Director, as well as a professor at the School of Nursing at McMaster University in Hamilton, Canada. And I would like to welcome all of you who are joining us today. And as we come together today from across the world for this global NFP webinar, I would like to begin by acknowledging that I am joining and currently sitting in Guelph, Ontario, Canada, which is situated on the ancestral lands of the Attawandaron and Haudenosaunee peoples and the treaty lands and territories of the Mississaugas of the Credit First Nation. And this land has long been home to diverse Indigenous nations who have cared for this land, waters, and families for generations. As a collective, we recognize that colonialism, dispossession, and broken treaties continue to impact Indigenous communities across many of our lands and countries. And in particular, this impacts so significantly mothers, children, and families. And as we focus today on supporting family and child health, we must also acknowledge that our healthcare and child welfare systems have not always been safe or equitable spaces for Indigenous peoples. We also acknowledge the painful legacies of slavery, where Black families were forcibly separated and denied basic rights. And the impacts of these histories are not in the past. They are embedded in our institutions, our systems, in the social determinants of health that continue to shape outcomes for families. And as I think about the work that we do within working with families, within our global nurse family partnership community, I think about the responsibilities that we have within our practice, within our policy, within our research. And some of these responsibilities are to continue to listen deeply to the voices of Indigenous, Black, and racialized families and communities, to continue to advocate for and co-develop through research, through practice, services that are culturally safe and trauma and violence informed and that are anti-racist, and really to think about how in our own unique and individual roles we can really support policies and practices that advance reparative justice and reconciliation. So may our work today and every day be guided by truth, responsibility, and collective service. So thank you for being with me this moment and taking this moment to reflect on these histories, our responsibilities, and the work that lies ahead. So now as we turn to today's webinar, I'm very honored to be sharing this space with all of you who are truly committed to improving the health and well-being of families and children, again, through research, through your home visiting work, through practice and policy. And so here's how today's session is going to unfold. We will start with our webinar and our presentation by Dr. Venice Williams, who will share her findings from recent work and speak to us about building systems of care to improve outcomes among families engaged in home visiting. Following her presentation, we are so grateful and honored to have Dr. David Olds, who is the founder of Nurse Family Partnership and a professor in the Department of Pediatrics at the University of Colorado, who will then offer a brief commentary and reflections and start us off with the first question for Venice. During the presentation, any of you who have questions, I encourage you to write your questions in the chat function. And as time allows, we will answer those questions as well as have time for you to pose any additional questions for discussion to Venice. And we'll do our best to get through as many as these. So with that, it's truly my pleasure to introduce Dr. Venice Williams, who I first met, I think, at least a decade ago when she was completing her PhD in health services research at the Colorado School of Public Health. She is now an assistant professor of pediatrics at the Prevention Research Center for Family and Child Health at the University of Colorado. And within this broad global community of NFP researchers, Venice truly stands out as a leading voice in advancing our understanding of interprofessional collaboration and care coordination, and especially has provided the field with unique insights on how nurse home visitors partner across different sectors, health, child protection, to support families. And it's my assessment that her research really offers us with critical insights into how trust and communication and shared goals really shape the success of evidence-based home visiting programs like Nurse Family Partnership. So Venice, welcome. Thank you for joining us today to share with us your insights and your research, and I turn it over to you.
Thanks, Sue. I'm humbled. That was a very humbling introduction. Very pleased to be here, invited to share with you all some of our learnings from not my own work, but my entire team's efforts over the past decade or so of research at the Prevention Research Center. So welcome, and appreciate Sue's land acknowledgement. I'm physically in Golden, Colorado in the United States, which is the traditional ancestral and unceded territory of the Cheyenne people, although many tribal nations cross this pathway over the past many hundreds of years. And I think while acknowledging the land is important to recognizing and respecting our tribal nations, we need to think about how that takes place within the larger context of ongoing work to really understand and challenge the ongoing legacies of colonialism. And here in the US in particular, I think we still have a lot of work to do. We need more dialogue. We need to cultivate stronger relationships and really stand in solidarity with our indigenous communities. With that, I usually like to start out with kind of letting you know who I am and kind of a little bit more about my positionality. I'm a wife, a mom, a daughter, and a sister. Career-wise, I identify as being a mixed methods health services researcher. In particular, I'm really focused on improving the delivery of prevention programs like Nurse Family Partnership to support families who experience adversity. And so I do that through collaborative, community-engaged research within the lens of my own lived experiences. I am a first-generation immigrant and a first-generation college graduate. That being said, I'm also an academic sitting in my ivory tower or my lovely office in my own home. And that means I hold power and privilege to do certain things that our practice partners, like many of you, and the families that are affected by our research do not have. So that's where I stand, and those are the kind of experiences that I bring to my work. So with that, before I get started, I'd love to acknowledge our funders and practice partners and many, many people who are involved in this work. Much of the work I'm presenting on is funded from the Robert Wood Johnson Foundation in the US. Want to acknowledge our practice partners at Changeant, which is previously the National Service Office for NFP and Child First, our local NFP teams who participated in this research, our advisory committee that you see listed here, including Dr. Olds, and our research team, which includes many investigators and statisticians and qualitative researchers and project managers who really allowed this work to happen. So my goal over the next 40 minutes or so is to really help talk through how we conceptualize cross-sector collaboration or systems of care, primarily for families and facing adversity and kind of within the early childhood system in the US. Describe measures that we've developed and validated of collaboration in the home visiting setting. Describe how collaboration has changed in the program over time, at least in the US, and how collaboration has affected programs, NFP program outcomes. And then hopefully end with some tips or best practices for you all that might be helpful for your ongoing work in building collaboration with different types of providers in your community. So I think it's always helpful to define terminology and make sure we're all grounded in the same kind of understanding. So when I talk about cross-sector collaboration, I'm really thinking about sectors across public health, medical care, and social services. So those are the three major sectors that I'll be referring to throughout today's presentation. And it's an alignment of both the people and organizations that deliver these services, but also those that are financing or funding these efforts. And really involves providers and communities across these sectors to focus their expertise and knowledge, but also their physical resources to solve complex issues. And that's usually often with a shared goal or a shared purpose in mind. So why think about cross-sector collaboration? Why is that important? So in the US, the systems of public health, social services, and medical care often fail to connect. because we're fragmented, we're in silos, we often work in silos, and that often leads to duplication in services and duplication in care. At the same time, there's a lot of variability in practice within these systems, across communities, which makes things a little more challenging. Within medical care, we know there's lots of issues in terms of access, and the tendency for medical care in the US to be more reactive in nature compared to the preventive services that public health tends to provide. In the public health system, there are many, many resource constraints. I think many of you can attest to that, especially with the current geopolitical landscape of resources and funding cuts. But beyond that, I think the public as well has limited understanding of public health as a system, as a service, and what we try to achieve. So all of those things kind of lead to waste and inefficiencies in how care is delivered and services are delivered, which ultimately leads to inequitable outcomes, particularly for families that experience adversities and the families that are supported by NFP. So as a result, cross-sector collaboration has been posed as a potential solution for these issues or for poor health and inequitable outcomes. In fact, it's been, argued that service coordination can ideally improve program inefficiencies, reduce that duplication of services, and allow providers to align their messaging with families. We've also learned that public health service provision requires collaboration to be most effective. But in the scientific literature, the role of collaboration in improving health outcomes is actually mixed. We see some more process outcomes that seems to be effective. For example, better collaboration across sectors and partners seems to improve service planning, building capacity for our workforce, and developing services. But it's not clear how we can optimize partnerships to really produce long-lasting population health effects. Related to cross-sector collaboration is this idea of systems of care, building systems of care. And in particular, I think that's really helpful to think about within the context of families who face adversities. We know that here in the US, child poverty is greater than in most other well-resourced countries, and that public health programs in the US use home visiting as a way to kind of help families achieve economic self-sufficiency and address some of those poor health outcomes that we talked about. And technically, really, home visiting programs are and should be part of a broader system of care to improve family well-being, because we know that families who experience adversities often interact with lots of different systems, from public health to public assistance and to child protective services, healthcare, and the list goes on. But like I said before, these systems are not designed to function cohesively. They're often not communicating. They often have little alignment in their goals and purpose. So where do we go from there? We think that we can align the delivery and financing systems across these sectors. We can create much broader systems of care and networks of care that can really improve the health of young children and families. So what is systems of care then? Like, what does that mean? There's a formal definition. I'm not going to read out the quote here for you, but these slides will be available. It's essentially a coordinated network of care that involves what I think is really true partnerships with their families. It's providing culturally and linguistically appropriate care and helping families achieve their goals to ultimately thrive. So I think there's a lot of parallels of what systems of care is to how NFP is intended to operate. And I'll let Dr. Olds kind of reflect on that maybe a little bit at the end. There are two kind of major aspects to the systems of care approach. There are core values that you see listed here, as well as some guiding principles. These core values are being family-driven, community-based, and addressing cultural and linguistic differences, which I think also aligns with how NFP operates. The guiding principles, there are many, but as you kind of look through the bullets, it's like these are all things that I think NFP nurses strive to do. And in particular, interagency collaboration and care coordination are the specific aspects that I'll speak to today about how all of this kind of comes together to really build these systems for our families to ensure that their needs are being addressed and ultimately have good health. So other literature not within the home visiting setting, largely in child welfare and so forth, has shown that having these coordinated systems of care and networks can lead to improvements in health, both in child well-being, child safety, and family functioning. It can also lead to increased use of evidence-based practices for our practitioners, better care management, and overall better investment of resources, which I think is ultimately what everyone is trying to, ensuring that the families are in the right services at the right time. So that's kind of the context I'm hoping provides, enough background for you all and thinking about collaboration and systems of care. And that's kind of how we've kind of come to this over the past 10 years. And I'll show you kind of our initial thinking about 6 years ago or 5 or maybe more. This is how we initially thought about the theory of change, of how collaboration might lead to better outcomes. So on the left-hand side is where we start. We see this alignment of systems, these shared goals, and having leadership and finance mechanisms, as well as interpersonal factors that we think would then lead to increased care coordination. When we coordinate care better, we would believe that our clients' needs are being met. And if their needs are being met, ideally they're being retained in the NFP program. If the program is being delivered according to, with fidelity and so forth, that would ideally lead to increased self-efficacy among our families, which ultimately leads to reduced risk for poor outcomes and better health outcomes in general. And we know that, there are client level factors, nurse level factors, site characteristics, even policies in place that might affect how all of these things happen. So this was initially how we thought about the mechanism of action. Better collaboration, theoretically, should improve better outcomes. Little did we know that there are many other things in play. So then we've created this new conceptual framework of what we think contributes to building a system of care or collaboration across sectors within the early childhood and family kind of systems, which I think kind of nicely aligns with the socio-ecological model in some ways, for those of you who are familiar with that. So families are at our center, families who experience adversity. As we branch out further, we see that it needs to involve care coordination to ensure that the needs of our families are being met. So you'll see these circles with different provider types listed. These are the provider types that we've included in our research within the NFP setting. This is by no means all the providers or community service providers that interact with our families, but are the ones who were most salient and really came across as the most often collaborated with or so forth. So we see prenatal postpartum healthcare providers, pediatric healthcare providers, mental health and substance use treatment. So those are kind of our healthcare sector. There's child welfare, which is more social services. So that's child welfare / child protective services or human services, depending on your locality, might have different names. Nutrition providers. So in the US, we have the special supplemental nutrition program for women, infants, and children, better known as WIC, which supports access to healthy foods, and also breastfeeding or chest feeding support and other things like that. Parenting programs, other home visiting programs, housing resources, and finally early intervention, which is Part C. Early intervention in the US is for a federally funded state operated program for kiddos at risk for developmental delays up to 3 years of age. So these are, there's probably other ones you're thinking about. They'll say, oh, like, what about like education? What about the criminal legal system? Of course, they're also related, but for the purpose of this presentation and our research, these are the providers we focused on. So we see collaboration as that alignment of public health, medical care, and social services is up here. That requires an integration of resources. So those are structural factors. Sorry, I need to advance my slides. We talked about that coordination piece. The relational coordination piece, let's talk about that first. So like I mentioned, it's collaboration is going to be a function of both structural factors and relational factors. These relational factors are things like things between people, between providers. For example, having shared goals, shared knowledge of each other, respecting one another, how we communicate. And so over the course of our work the last few years, we were able to identify some measures and develop measures to capture that. And in particular, we identified a 7-item validated instrument called the Relational Coordination Scale. And this measures high quality relationships plus high quality communication. And so it measures the frequency of that communication, how timely is it, how accurate is it problem solving in nature? So that's a high quality communication. In terms of high quality relationships, we're measuring the extent to which NFP nurses and these different types of providers have shared goals, shared knowledge, and mutual respect. So you see some alignment with these, the yellow kind of orangey, colored box there. So that coordination needs to happen between providers, but we also need to look at how, organizations are sharing resources or integration of resources. And we have developed a 4-item instrument that measures those structural factors between organizations, in particular measuring physical space, the extent to which you share that space, the sharing of information systems. Usually that's an electronic health record or some sort of data collection system of some kind. Shared policies or agreements that facilitate collaboration, as well as shared funding or financing mechanisms that encourage NFP and home visitors to collaborate with other providers. So given this framework and these 2 measures, we embarked on some survey research from 2018 to 2021. And censused all of the NFP nursing supervisors who supervise active NFP sites in those respective years. Had really great response rates. Actually, in 2020, at the height of COVID, had an 85% response rate, which just kind of shot us through. Yeah, we were just unexpecting that, but have response rates between 71% to 85%. What that means is that represents over 200, almost close to 300 teams across the NFP programs in the US, which covers over 200 sites in 39 states and territories. So pretty comprehensive, pretty representative of the NFP programs in the US. The majority of those are public health departments or government agencies, about half, and about 20% are operated out of health systems or clinics. About a quarter out of community-based organizations, and then the remaining 3 to 4% are other institutions like educational institutions that implement the program. So what did we find? So we measured that relational coordination, so that communication and relationship piece, and then we also measured that sharing of resources, that integration. Across all the providers, so the 10 provider types that we ask about, we found just moderate relational coordination. You see these means of about 3. It can range from 1 to 5. So we're right in the middle, but we wanted to dig deeper. So like where is that variation happening? We saw the highest coordination with WIC, so the nutrition providers and our women's care providers. And the lowest coordination was reported with substance use treatment and housing resources. In terms of our shared resources, the extent of sharing that data, physical space, et cetera, we were also interested in looking at that integration across all providers. And we see a mean score of about 6 across the years. So you see not a lot of differences in the 3 years. And that's low. The range should be about 4 to 20. So that's really something to consider, is that sharing of resources across organizations seem to be, in general, generalizing across all the sites that participated is lower. But if we look more deeply by provider type, the greatest integration is with other home visiting services, and WIC, again, comes high. And the lowest integration is with the same providers that was lowest in coordination, so substance use treatment providers and housing. In addition to these findings, we started looking at how collaboration might vary depending on the type of agency that implements the program. So like I mentioned before, the majority of teams who responded were public health departments, and those are also the sites that tend to have stronger coordination and integration with WIC and home visiting services. When we look at our healthcare partners that implement the program, those tend to be the ones with the strongest relationships with primary care providers, such as women's care and pediatric care. Though the relationships and coordination is sometimes different. We tend to see higher coordination with women's care providers more than pediatric care, even within the same site. So then we wanted to look at whether or not collaboration changed over time, because we measured these collaboration from 2018, 2020, and 2021. So I'll show you some graphs for those who are more visual, but generally what we saw was improved coordination with women's care providers from 2018 to 2020, and decreased coordination as well as less integration with parenting programs in that same time period. And I'll tell you a little bit more about why we think that's the case. So this is a graph showing the coordination scores by year. For each provider type, you kind of see the 3 years lumped together, 2018, 2020, and 2021. The ones with the little blue box with the F statistic on there shows statistical significance in these scores over the time period. What I'll highlight here is women's care. You see the jump from 2018 to 2020. We see that increase in better coordination. We think that might be due to, the COVID circumstances where, everybody was like telehealth and remote, and there was a stronger need to really identify and communicate about really any challenges in that prenatal care period. That's why we think that's the case. You can see there's some variation for some of the other provider types. WIC in particular, that first series of bars there, it goes down from 2018 to 2020, but that was not statistically significant. And then the only other one that was significant was parenting programs. We see that big decrease there from 2018 to 2020. And we think that's because we actually added a provider type in that same year to the survey. So you can see home visiting only has 2 colored bars. We don't have other home visiting services. We didn't ask about that in 2018. We think that's why we saw that jump, is that people were lumping those 2 categories together. And so by splitting them out, people's responses went other places. And that's likely the case here when we look at our integration scores and how those changed over time as well. Essentially, really no major differences in the sharing of resources over time in this period, other than the parenting programs, which you see that really big decrease from 2018 to 2020. Again, we think that's because of adding that provider type into the survey that's causing that. So this is not like a true change that we're seeing in practice, but rather more of a measurement change. So that's what we found. So in summary, not a lot of changes in collaboration, at least from 2018 to 2021. That's a summary. We did see that minor increase for coordination for women's care providers. I would be really curious to see what things look like current times, 4 years from this last survey. So stay tuned if you are an NFP nurse supervisor in the US. We may or may not be doing more surveys. So, we found these ways to measure and quantify collaboration. Then we were really interested to see, well, does collaboration actually improve outcomes in the program? And so we used the collaboration survey data. We also implemented a survey, measuring the primary funding sources of our NFP sites to capture that alignment in financing systems that wasn't available to us through existing data. Where we asked nurse administrators to complete a survey providing their kind of top 3 funding sources, and then we categorize those into different sectors. We also use program implementation data from the NFP program in the US, as well as publicly available neighborhood level data. So we included clients who had a first visit between January 2015 through December of 2021. We wanted to include clients who would be captured during the time we have the survey data. We matched clients to nurses who conducted their first 4 home visits, and only included clients that had 4 more visits for some sort of, there's some dosage there, right? They received NFP at least a little bit. And excluded any individuals who left due to addressable reasons like moving or unaddressable reasons like moving or miscarriages and so forth. We wanted to control for things that we think might affect our outcomes in some way. So client level characteristics like race, ethnicity, baseline health, etc. Nurse level characteristics that we had access to, site level as well. So things like the type of agency that's implementing the program, and then some neighborhood level factors. So the outcomes we primarily looked at are kind of threefold. We wanted to focus first on program implementation, knowing that that's needed. Clients have to be retained to kind of see those outcomes that we want to see. So we looked at client retention at different time points at birth, 6 months, 12 months, and 18 months. We also looked at referrals to different types of services. The idea is that better collaboration would lead to retention in the program, would lead to more referrals or more likelihood of referrals. We also wanted to examine some maternal behaviors. We thought that maybe if there was better collaboration, we might be able to motivate more health promoting or health seeking behaviors like smoking cessation, the prenatal period, or breastfeeding or chest feeding practices. And then use of services as well, is that if once referred by their NFP nurse, better collaboration would lead to actually access to and use of that service. And then infant health outcomes we looked at were low birth weight and preterm birth, which similarly is related to hopefully, maybe smoking cessation. There's some kind of, interactions there. So what did we find? We conducted a series of what we call mixed models or hierarchical models because that controls for many clients that might be served by one singular nurse, and included those different levels of care factors that we know contribute to these outcomes. And we're primarily interested in how both the coordination measures and the integration measures might affect these outcomes. So what we found is, unsurprisingly, collaboration matters, but not for all of the outcomes. So we'll dive deeper. Specifically looking at client retention, we found that more integration, so that sharing of resources across organizations with child protective services in particular, was associated with increased odds of client retention at multiple time points. However, more integration or sharing of resources with other home visiting services and Part C early intervention for kiddos with developmental delays was associated with lower odds of retention. So we thought that was kind of interesting. What's going on there? Is it because maybe there's some level of competition with our other home visiting programs? What is it going on with our early intervention? We're not quite sure what's the case there. Then we looked into some other outcomes. This one looks at referrals to and use of services. There's a lot of bullets here, but the summary is that, yes, we do see better collaboration resulting in greater odds of service referrals, and once referred, greater odds of using that particular service. So what we did here was okay, let's look at coordination and integration specifically with a provider type and that service referral. I think what stood out to us is that, unsurprisingly, both coordination and sharing of resources or integration is important for service use, basically for most of the services we're talking about. But for some of our more, I would say, sensitive services, for example, mental health or substance use, or even early intervention for like developmental delays, that coordination was more important. It drove the odds of referrals and use even more so. So I think that's something to consider, is that, yes, like we need both coordination and integration, but when we're talking about very particular sensitive topics, having those relationships with those providers was more important. And then we looked at maternal child health outcomes. What's the relationship between collaboration? And found that better coordination with women's care providers and integration with mental health providers was associated with greater odds of breastfeeding initiation. And that relationship is sustained at for breastfeeding continuation at 6 months and 12 months, only with integration with mental health providers. And then in terms of these other outcomes of low birth weight, preterm birth, and prenatal smoking cessation, we did not see any relationships with collaboration. That's likely because there's other more salient factors that contribute to those and may not be as amenable or like can be, changed through collaboration. So that's what we found in our quantitative analyses. A couple things I wanted to also know that I didn't put bullets or slides for is that in these analyses, we also looked at, holding all else equal, how does agency type play a role? So the type of organization that implements the program, knowing that collaboration also varies by the agency type. And what we saw was that looking at, for example, retention. Our healthcare partners that implement NFP, so like through a healthcare clinic or health system, as well as educational institutions that implement NFP, have greater odds of retention at birth and at 12 months compared to our public health departments that implement NFP. In terms of, so that was interesting for us to think about how that might affect one of these intermediary outcomes of retention. Then you might recall I talked about how we had a survey that measured the sector of sites' primary funding sources to kind of capture that financial alignment piece. And so depending on what sites filled out, we then categorize, their funding source into public health sector versus healthcare sector versus social services sector. And so what we found was that NFP programs that are primarily funded by healthcare sector, largely those who are reimbursed by Medicaid, like fee for service, have lower odds of client retention at 12 months. Compared to public health funding, which is largely federal dollars or state, tobacco settlement or the federal McVie program funding. And then those who are funded by mixed sectors, so where we couldn't, it was like maybe a foundation that serves multiple sectors, or maybe a site that was primarily funded by, say, Pay for Success, where we knew there were a lot of partners involved in their funding. Those mixed sector sites tended to have higher odds of retention at the same time frame. So those were some additional findings we had where maybe the financing alignment of systems has some effects on at least client retention. So given these results, we wanted to dive deeper to learn from local NFP programs who have been really collaborative or, reported really strong collaboration in the survey that we conducted. So we ended up conducting 5 in-depth case studies with highly collaborative sites across the US. And they're de-identified, so I can't identify where they're located, but they're spread across the US in different geographic regions, representing different urbanicity, rurality, and so forth. Slightly different populations, some very small rural teams and some that were larger urban teams to kind of capture that variability. And across those 5 cases, what we heard was these kind of 8 best practices that I hope is useful for you and your practice, and happy to dive into these later on in our discussion. But first and foremost is that role of leadership, not just at the executive level or the nurse supervisor level, but leadership within the NFP team as well. That all of these individuals are promoting coordination and collaboration to occur, that they recognize the importance of collaboration. And that first and foremost requires executive leadership to understand and appreciate NFP nurses and the NFP model. So I think that needs to come first. And the NFP program is advocated for by leadership. So leadership is involved in expansion, sustainability of the NFP program. So those kind of factors need to be in place to then facilitate coordination. We also heard about the role of champions, so champions of the NFP program. And so we're thinking about collaborating, say, with the health clinic or with, the local housing service, a shelter, women's shelter, for example. We need to identify specific champions located in that organization who can advocate for the program. Oftentimes, those are people with a public health background or a social work background. That's usually the is they have that same kind of background and understanding of prevention. And then you kind of tell them, teach them about and educate them about the role of NFP nurses. What do we offer for our clients? What does the program do? How does it benefit the community? And then once you can identify that champion, they're able to create these mutually beneficial relationships with NFP. They help promote exchanges of service referrals. They can help create connections with other providers within their organization, and they can also reinforce messages with clients. In some places where you might have a state level intermediary, like here in Colorado, with Invest in Kids or Change It, at the national level, being able to provide advocacy support, financial support. I think those are other roles of champions, but at different levels as well. Then we also heard about shared goals and values, which, we measure in our relation coordination scale. So having these shared goals and values means that the people we're trying to coordinate and collaborate with needs to also share a strengths-based, family-centered approach and value the community of support that is necessary to meet families' needs, meaning everybody needs to be involved to help families access services. Typically, these are providers who share the goal of healthy pregnancies, healthy births, and healthy babies. So finding that similar alignment and a commitment to really supporting the same population, Medicaid eligible pregnant people with overlapping needs or adversities, multiple adversities. And not only a commitment to supporting or serving this population, but a commitment to develop a process to both identify this population and connect them to needed services. Beyond these kind of like high level things, it's that relationship, right? We're all relational human beings. How do we develop trusting relationships at the individual level that can facilitate care coordination? So finding that same people who serve the same population have the shared goals and values as you is great. But what are some concrete things we heard about was how do we maintain those relationships? In some sites, there are nurse home visitors are designated as specific partners. So they have specific clinics or specific organizations that they're responsible for, whom they are the primary contact. We've heard about personalized outreach, quarterly you might go in and, make an appearance and provide some flyers or posters or so forth. Considering inviting these individuals to your community advisory board, which I'll talk more about later, attending trainings together in the community, having that face-to-face interaction, but also regular check-ins or invitations for them to come to either your in-service meetings or you can attend their meetings to kind of provide that overview of what NFP is about and maintain those relationships. At the same time, we heard about the importance of shared data systems, having these like physical structures that really help us coordinate and collaborate is having a shared system of some kind. Most often time that those are electronic medical records or electronic health records, depending on what system you're using. And that those can actually be implemented, even if you're operating out of a community-based organization or a public health department, it is still possible for NFP programs to have access to their clients' EHRs. So you don't have to necessarily be within the same health system to have that access. And that leads to 6, which is the formal agreements, which I'll talk about a little bit more. But these shared systems are really essential because they are platforms for communication, not just for referrals, but also for communication and coordination of care. So we heard a lot about, places in places where the NFP nurses have access to their clients' EHRs, they're able to talk about concerns like newborn weight checks or share their screening results from their ASQs for development or share depression results and have those conversations, discuss their client needs with the provider, advocate for urgent health issues that need to be addressed, or even follow up on prescriptions. Those are specific examples of how having these shared communication systems can be really helpful, as well as allowing for a care plan to develop, and increasing name recognition of the NFP program. In some places, like the NFP nurse is identified in the record, and that help facilitates, a provider who might not even know what NFP is would then ask the question, like, what is this flag? Who is this person that's like listed on their EHR? So it provides an opportunity for education and learning as well from the healthcare provider side. So as I was talking about policies, how it is possible for community-based organizations and public health departments to develop data sharing agreements or memorandum of understanding with their health system partners to have that shared data linkage of some kind. Oftentimes, these policies really support communication, coordination, sharing of information, and like not having to do an informed consent every single time or every single time you want to talk to a new person, making that less burdensome for both nurses and our family partners. Other aspects might relate to having a co-location of some kind, so being either in the same floor or the same building or the same campus can sometimes help make referrals, for example, more efficient. You can walk your client down the hallway to get them enrolled in a specific service. But I will say that's not the be-all end-all. Being physically co-located will not always facilitate better collaboration. You still need to have that relationship, and you still need to have that shared goal in mind. And like, the shared data systems, having this shared space also increases name recognition of the NFP program. Just so you have those faces, you see those same people, you might see a poster, and so forth. 7 and 8 are related. So 7 is having a strong community advisory board, and 8 is just this idea of general community commitment. And so some of the successes we heard about in our community advisory boards, we hear about the range of implementation of CABs, right? And how some are very effective in supporting implementation. Some may just occur because they used to be a model element. So I think there's some lessons learned here, which we heard from some of our really collaborative sites, that when there is identified goals, having a formal chair, having structured meetings and minutes really help. These kind of basic logistics, that we think about, really help facilitate a shared goal and having a sense of purpose in doing this work together. We really encourage diverse representation across sectors on your CAB. So many times we hear about having like different, OBs or primary care providers sitting on your CAB, but maybe consider some of your non-traditional partners who might be involved in transportation, can help facilitate access for our clients. Who are those who work in the criminal legal system who can maybe provide that perspective? Or even local businesses. We heard about some, it was like a local food chain restaurant that was partnered on our CAB, and they were the ones who provided the location for graduation, for NFP graduation. So really think outside of the box a little bit about beyond the traditional partners you might engage with. And then of course, inviting people with lived experiences, whether that's NFP graduates, other families in the community, that really helped lend a different perspective to your CAB. Other opportunities we think about in terms of the CAB is that beyond just providing updates, numbers on like, oh, here's how many referrals we received, here's how we're doing. It's an opportunity for members on the CAB to connect. It's like you want to be able to also share resources that are not only relevant for your clients, but also maybe resources that are relevant for your home visitors as well. And in some cases, having a multi-site or multi-program CAB can be beneficial. If you're in an urban city and you have multiple NFP programs, it's actually very helpful to convene everybody in one place and not duplicate efforts. Or if there's multiple home visiting programs in your organization, having a shared CAB can be effective as long as the specific needs of NFP are being met. And then lastly, in terms of shared community commitment, is thinking about your broader community, your individuals, not just the partners, the providers and organizations, but the community as a whole. How can they be involved in building these reciprocal, trusting, respectful relationships where there's not really competition between organizations? You can find like-minded programs who want to share resources, make those referrals to different programs, and really make sure that clients are in the programs they would benefit most from, and working together to support program implementation, which also involves identifying sustainable funding for NFP. So those are kind of some of the main best practices that we heard across our 5 cases that I hope are helpful for you in your work. And I'll end with a discussion or quick summary of this work that we've been doing over the past 10 years, is that yes, collaboration dynamics are complex, but we can still measure them. And the way we measure them is a function of both relationships and these facilitating structures or sharing of resources through 2 scales, a relational coordination scale and the structural integration scale. We have also learned that NFP nurses collaborate with a broad range of medical care and social service providers, not just the ones I talked about today, and that they're all really involved in wanting to build this broader system of care. But that collaboration ranges. It depends on the community. There's a lot of differences across different communities. But in general, at least in the time frame that we did our survey, we didn't really see a lot of major changes in that degree of collaboration. And that collaboration matters, but not necessarily for all NFP outcomes. And that collaboration with specific provider types might be more important than others. In particular, we talk about specific outcomes. And that while there are structural factors that can help facilitate collaboration. I think those are harder to achieve. What I think is maybe easier potentially to identify is finding those organizations in your community that share your goals, share NFP mission, that you can identify those program champions and support. That's really the beginning, is developing those relationships and maintaining them that can really support effective collaboration to meet the needs of our families. So with that, I will stop. And I know I've provided a lot of information, so happy to answer questions. I know David, Dr. Olds was going to reflect a little bit on this. So should I stop the slide so we can see you better? Yeah, I'll do that.
So, Venice, I just want to thank you. This is a really thorough, deep, valuable presentation. So thank you. I know that that's what a lot of people in this symposium are reflecting on as well. I apologize because I know that I've raised these questions a few times in the past, but I just want to emphasize a couple of things. One of them is that retention is um, is highest in those settings where it's in the program NFP is run out of healthcare service settings itself. And I think that my reflection is that this creates a context where nurses and primary care providers can communicate with one another. And it seems to me that when we're talking about pregnant women, parents of very young children, the issue that is most salient in their minds for the most part is, what does this back pain mean? What does this discharge mean? Nurses are in a position to take blood pressures, check for edema, check for urinary tract infections, observe the needs of the newborn baby in a way that promotes um, deep coordination around things that matter the most to those mothers and their families. And so it seems to me that that's something we need to keep in mind, that that aspect of coordination, in my view at least, is really critical. And then the the other thing is that it was striking to me, and it has been for some time, that when the program operates out of public health departments, the rates of retention tend to be lower. And I wonder whether the hiring practices in those settings give greater emphasis to things like seniority within the organization, or as opposed to other organizations that can really give greater focus to on nurse interpersonal skills. So the history of and the structure of hiring the right nurse is mitigated in some of those settings when where there's not a focus on the strength of the interpersonal skills. So um, I just one final thought. This aligns so beautifully with what the one fundamental theory of the program is, and that's human ecology. And what you've done is you've taken it to a whole new level, and it's really helped us think much more systemically at the community level. So I'm really grateful to you for everything you've done. So, in any case, what do you think?
Which question am I trying to answer first? I will say, I think it's really interesting. So the first thing you talked about was how, NFP programs that operate out of our clinical, more health system oriented programs, we do tend to see higher rates of retention of clients. And I think that there's so many different factors that come into play, and that comes into play with the hiring piece as well that you're referring to. which is a whole different project that I can also speak about maybe at some point. But in that project, we really focused on organizational factors that might contribute to nurse retention and client retention, knowing that there are differences in how NFP nurses are recruited depending on the type of agency. So in our public health departments, there might be more restrictions. Some, depending on your locality, have certain requirements like unionizing. So what you were referring to, like having that seniority. Sometimes people in other programs get transferred over who may not be the best fit, which then contributes to client retention issues. And then also, like how they hire in general, the job descriptions, people who operate out of public health departments in certain states can attest to this, is that sometimes the descriptions are very vague. We say we're hiring a public health nurse, but don't specify what that means. And that's problematic, right? Because we want to know, candidates want to know what they're getting themselves into, but also have an opportunity to assess, is this a good fit for them? I will say there are health systems that have similar practices, though. There's a few that we've encountered where they have that same issue, but many nurse supervisors are very creative, probably many on the call, and they can work around some of those challenges by word of mouth hiring, direct outreach to, nursing schools or those who've been rotating through public health nursing. So I think there are many strategies that local sites have employed to overcome some of those systemic barriers that affect client retention that, is related to collaboration in some ways. So that's kind of my short reflection there.
Great. Thank you, Venice. And David, thank you for your thoughts and reflections and that question to start us off on. Venice, such a great presentation. And I grabbed a photo of your best practices for successful collaboration, thinking about what a rich place that will be to start discussions at many tables with NFP nurses and supervisors and managers. And really excited to see that questions are starting to come in. I've got a few that were sent here ahead of time, but I see in the chat that Sandra's asked one there. Did you see any NFP sites that were partnerships between two different agencies to come together as one site? Our program in Yakima, Washington is a collaboration between a hospital system, oh my gosh, an acronym, sorry, and an FQHC. Although it comes with many challenges, it can also be a great strength to have so many partners in our corner.
Yeah, so that's a great question, Sandra. Thank you. Yeah, Federally Qualified Health Center for our non-US participants. We didn't specifically look at that measurement in some way. We probably categorized your site as a healthcare sector agency type, because it's both, both the hospital system and the FQHC would qualify under that. I do think that would be really interesting to look at a little bit more in terms of, in some of the places we've looked at our qualitative work where we dug into the history of how these sites were created. I think that could be something really interesting to potentially explore in the future, is well, how did they decide who's going to be operating the program? Is it, like you said, two agencies coming together? How are those decisions being made to, even invest in the program in the first place? So sorry, I don't have a great answer. Short answer is no. Long answer is I think that would be interesting to explore.
Great, thanks, Venice. And Venice, reflecting on something that David mentioned, that you've taken, this work to another level and reflecting on the ecological theory. Now, going to a question that's at a very practical, clinical level, is in any of this work, and particularly in your case studies, do you have any insights that you can share with nurses and supervisors on what strategies nurses can use to support their NFP clients accept a referral to some of these service agencies or collaborating partners?
Yeah, that's a great question. I think it depends on the service. What it depends on what organization are we trying to refer to? Is it something that's broadly accepted by many people that has a positive perception by people in the public, or is it an organization or even there might be a need for it, but there's negative perceptions for some reason of this particular clinic. So I think, and that's really relying on that nurse-client relationship, right? That therapeutic alliance. I think that's first and foremost, that needs to be present before anything else. So nurses do what they do already, like that you're so good at, you're using your MI skills and so forth to develop those relationships with your client, and really establishing where they are at in that stages of change and readiness. So there's that piece of it that I think is inherent to the NFP model, where then I think it's important is then the NFP nurse should have some relationship of some kind, right, with that organization, whether it's a specific provider or a specific contact at that organization. They need to have a specific person that they know they can rely on, it's not just a referral that's being made, but that like there's connection that's going to be made after the referral, and that they ideally may have some understanding of the process of what that intake might look like, what maybe prepare the client for what is to come. Like you might hear from so-and-so in X amount of days. So being understanding what that process might look like, or like maybe if it's housing, maybe it's going to take a month. You might not hear for a month. So I think it's preparing our clients for what is to come and what they can expect. And that requires a relationship with the other organization.
Thank you for highlighting
Yes,
that.
a warm referral, exactly.
Warm referrals, absolutely. And thank you for highlighting this, because even in your best practices framework, it talked about the importance of having support from senior leadership. A lot of work of nurses is invisible, and often what gets counted in different countries is how many visits or how many hours. Yet I think your findings here speak to the importance of recognizing the need to recognize the work that nurses do early on when programs are implemented in a community, giving nurses time, valuing that time for them to build relationships, to go out, meet other service providers, meet agencies. And that's not something that they should just have to squeeze into their practice, but that is at the forefront of the program, that it's valued and recognized, that nurses have time to go build these relationships. So thank you for highlighting that. Now, another question that came in before the webinar was, do you have any recommendations on how programs can help to retain clients once a mom seems to have a handle on parenting and wants to leave the program?
Yeah, that's a challenging question. I'm sure there are many others on the call who probably have really great strategies, like on the ground service, delivery strategies. This is my own opinion. Okay, this is my own opinion. I think there are certain moms who may benefit through the duration of the entire program. And then I think there are certain moms who may want to need or can and should graduate early. That being said, I think there are always ways that an NFP nurse can engage with a client in establishing longer term goals. What are those longer term goals that maybe they can help them achieve, even if their immediate needs are met? What are those longer term goals? What are things that maybe we can support you to get there, and really create opportunities for them to self-advocate for themselves, and have those opportunities. I'll start with that. And David, I'm sure you probably have reflections too on that question.
I can say this, Venice. I think your response was great, and I think that's one of the reasons that we introduced this idea of adjusting the frequency of visits depending on the needs of the client, and in particular, we now have telehealth ways of keeping in touch. If someone is getting on with their life, they're going to be busy. They're going to be busy with school or work and caring for this child. And so having a brief check-in just to make sure everything is going okay, it seems to me is a good way of maintaining connection and making sure that things are not going south for this family in some way. So that's my quick thought.
Thank you. And this, it continues to be a question that is asked in different contexts. And, in a moment of perhaps self-promotion, just in the link, I've just put a link to an article that was just published on May 31st, a Canadian study looking at strategies to engage and retain pregnant individuals and young mothers in NFP from a Canadian perspective. However, I think many of the factors that our research team identified at levels of the client, of their families, of their living situation, nurse and programs will be transferable across different contexts. So I put the link there. There's about another 40 days where access to this article will be free. And then it will be published as part of a special issue that David and Dr. Gregory Tung and I are guest editing in the Journal of Child Abuse and Neglect. So just sharing that as well to augment what David and Venice have already shared. So Venice, another question. What are the primary barriers that your research has demonstrated serve as barriers to a more connected and integrated delivery system of human services?
Not a loaded question. Resource barriers, right? It's time and money. I think that's really the basics of it all. To your point too, about earlier about how, a lot of the work that nursing visitors do is invisible. It's not credited, it's not paid for, it's not reimbursed. That's one fundamental issue, is that we don't have enough time in our days to do all the work that we want to be doing. That's why we should collaborate, right? So that we can be more efficient and kind of address any duplication of efforts. But if the money's not there to support that, at the end of the day, you're just going to continue to do what you do, what's easiest for you to do. So I think there needs to be fundamental changes to how we finance these different systems that then will facilitate the delivery. Because it's not that people don't want to collaborate. Well, let me say most people would like to collaborate with others and have that desire. They just either don't have the means, they don't have the resources, or they don't have the time.
Right. And in most systems too, there's such siloization, right, of sectors with their own values, missions, mandates, and as you say, funding models. It makes some of this cross-sector work a challenge.
Especially here, I think in the US, where there are many different delivery models and many different financing systems, the lot of variation by state, even by localities, that makes it even all the more challenging.
Yeah. Oh, great, thank you. And just there was a great comment posted in the chat back to our other question, and it really speaks to the importance of language, maybe reflecting on the value of using the strength and risk framework, assessing when clients are ready to graduate, and again, the importance of language. And I'll just read the comment. Graduating clients early would be a good option to have rather than calling it an early discharge. Then often, depending on the site, they may not get credit for graduation when clients are doing well, thriving, and services are no longer needed, and other referrals are waiting to be enrolled or missing out on enrollment. So a very thought-provoking site or statement for sites to consider when they're thinking about that endpoint for clients. So thank you for that comment. Another question that's been posted in the chat. How can your innovative program deal with issues? Okay, so thanks for a great talk and discussions on family-centered and integrated systems of care. Examples of clients' outcomes seem all health-related and individual behaviors. How can your innovative program deal with issues such as intimate partner violence and firearm violence epidemic in the US?
It sounds like, Sue, you might be the better person to respond to that question. Yeah, I mean, I think intimate partner violence is definitely one aspect that's already addressed in the program through your work, Sue, and the innovation developed through the screening and referrals, and just those conversations about adopting trauma and violence-informed practices into how NFP nurses operate. I think that's really one key step. It sounds like this is a question maybe thinking about systemic issues, like how as a whole, this is in the US in particular, that there's a broader systemic issue of violence. And I think that's difficult, right? It's thinking about NFP, which is more of a relational program in nature. At the same time, we're we encourage y'all to work within your communities, right? Like that's what this whole project is about, is there an opportunity to collaborate with other collaboratives in the broader community to maybe address some of those systemic issues. So being a partner in that and not necessarily leading the efforts, but providing a voice, providing a family voice in those conversations. So that's one thought I had.
Great, thanks, Venice. And as we begin to wrap up here, Venice, in recognizing that there's many professional practice nursing leads on the call from different countries, managers, supervisors, if they're to go back to their teams of NFP managers, supervisors, and talk about one key message today around how they can work locally to promote better collaboration between NFP and other services and supports in their own community, what would be your key recommendation for them as an action to think about?
Ooh, that's a toughie. I would say like leveraging your family's strengths and voices. Let's hear from our families and how can they help us achieve these goals? Because I think that's really, nurses are already doing great work collaborating with clinical providers, like we're already doing a lot of this work is already happening. I think we're, at least in the US, I feel like we could do a lot more in uplifting family voice and learning from our families and their experiences and using those voices to help us get to it. Because really it's the stories, like data is important, but stories is what moves people. So that would be my message.
Great. Well, thank you very much. I mean, that's such a lovely way to end on valuing and raising up the stories and the experiences of the families that are enrolled in NFP. So Venice, I would like to thank you on behalf of the Global NFP team for joining us today, for sharing your wisdom, your expertise, your research findings that continue to contribute to the incredible evidentiary foundations that underpin NFP. So thank you for the work you do. Thank you for sharing. And thank you to all of you from across the globe who joined us today for listening to these findings and taking away these ideas back to your sites. So stay tuned, everyone. We will have another webinar in September. Our topic and speaker are to be confirmed, but anyone who registered today, we will certainly have information sent out to you over the summer. Thank you to Anna Lindberg for her excellent coordination in getting the webinar registration and up and running today. And David, as always, thank you for your thoughtful comments and reflections. So thank you, everyone, and have a lovely rest of your morning, afternoon, or evening. Take care, everyone. Bye-bye.